Muharrem Yazıcı to, I'm probably saying the name in the wrong way. I'm sorry for that. But I know your face. I know who you are. And so you are going to talk about management of syndromic cases, please.
Oh, can you hear me?
Yes.
My screen is seen well? Great.
Yes.
Okay. Thank you, Dr. Aebi. And also, first of all, I'd like to thank organizer for having me at this fantastic webinar with a great faculty. I've been tasked about to speak to instrumented fusion in congenital spine deformities. Unfortunately, some of my slides will overlap in Dr. Aebi's slides. Okay, just a second. Okay, we'll go back. Okay. As all we know, congenital spinal deformities are among the most challenging curves to correct because they're complex, they're progressive and rigid, and they pose difficulties during correction. It's not necessary to treat all congenital deformities, but if treatment is necessary, the method should be surgical. Conservative approach have no place in the treatment, but I fully agree with Dr. Falun, and in some cases, some congenital deformity having a big compensatory curve. For time-buying strategy, we can use the brace or cast in a certain period of time in their growth. This is the two cases in my career, and both of them as a congenital anomaly. One on the left-hand side, I saw first when he was in the 5-year-old, looks as all the spine is having the multiple congenital anomalies from top to bottom, like a pebble bone. But in coronal and sagittal plane is very well aligned. We didn't do anything at the end of the maturity, and the body the height was significantly short, but no deformity. That's why he definitely didn't need any surgery. The second patient in the right-hand side on my screen is the deformity as a typical hemivertebrae between L4 and 5. Incidentally diagnosed when she applied to emergency department because of the bladder stone, and then the spine is well aligned, no significant deformity, and the patient is happy. Just only thing maybe we can say is the congenital and spinal stenosis. Maybe she needs some decompression in the future. Surgery for surgical decompression, but not for the spine deformity. Historically, correction and fusion with instruments have been avoided for many years in the treatment for congenital deformities for 4 main reasons. Surgery is too risky for these patients because of accompanying interspinal pathologies. It is too difficult to perform because of bone malformation. It is too complicated to achieve satisfactory results because of curve rigidity, and it is considered impractical because of current implant options are insufficient. Because of all these factors, until the early 1980s, surgeons were either compelled to utilize in situ fusion or only mild correction using cast followed by fusion. Despite being safe, this strategy of halting the deformity before it becomes evident is far from ideal because of the high rates of pseudoarthrosis and deformity progression. John Hall of Boston Children's published the first series of instrumented fusion in the literature, and his results with Harrington instrumentation were marginally better than those of traditional approach. However, in the last 45 years, many things have changed. We can now better evaluate our patients preoperatively. Our surgical and anesthesiologic techniques and technological infrastructure have improved significantly. We now have a wide range of implant options at our disposal. And finally, we have an extraordinary guide such as neuromonitoring. Thanks to these developments, we can achieve much more significant correction with safer surgeries today and maintain the improvements we have achieved. As a result, many things that we couldn't imagine in the past have become today's routine or today's normal. Today, we can operate in the patients of all ages, from 2-year-old babies to elderly patients. We can perform major reconstructions from upper thoracic, even cervical vertebrae to lumbar and the sacropelvic region. From simple cases similar to idiopathic scoliosis to complex cases accompanied with intraspinal pathologies. And finally, we can perform complex three-planar osteotomies in cases where simple posterior osteotomies are not sufficient alone. However, instrumented fusion still continues to be challenging for pediatric spinal surgeons. Our challenges can be grouped under the two main headings: instrumentation and correction-related ones. The smallness of the patient's bone dimensions and insufficient soft tissue coverage and malformation of anatomy make our instrumentation difficult. The rigidity of the curve and wrist and the sick spinal cord in a significant group of patients also limit the ability to correct. Placing a pedicle screw as a standard state-of-the-art techniques today can sometimes be very difficult due to the age of patients or congenital backgrounds. The presence of posterior bony defect may make hook use impossible. The discordance of congenital anomalies in the anterior and posterior columns of the vertebrae, as Dr. Aebi has clearly shown that, especially if not recognized before, forces the surgeon to make mistakes. In rare cases, rare cases, the lack of connection between the posterior and anterior elements makes it impossible to get a strong fixation from the back. Pedicle screw is gold standard today, but dimension mismatching is the biggest challenge for pediatric spine surgeons, in general, all deformities, but especially congenital ones. Years ago, in a study we conducted on healthy infants and juveniles, we showed that inner diameter of L1 pedicle was around 2.5 millimeters, and discussed that it was not possible to place screws with sufficient purchase strength in these pedicles with standard methods. Needless to say, the problem is more striking for a thoracic region. Our group also showed that the pedicles can be dilated in immature pigs, and that screws with larger core and thread diameters can be used safely. Today, we can safely use pediatric spinal implants even in 2-year-old children or younger by dilating pedicle channel. Sorry about that. Pedicle channel using incremental screws or tabs. Cervical implants can be alternative for instrumentation of children with small body habitus, especially in the thoracic apex or thoracolumbar junction. In this case, for example, the option of splinting this biomechanically weak instrumentation with cast or temporary internal bracing until the time of fusion should be kept in mind. In cases where there is no pedicle or screw placement in some reason is not possible for some problems, using in-out-in technique or simply hook placements can be a life-saving for surgeon. Although it is technologically possible to produce shorter and thinner screws, certain size of screws, but certain size of the screw heads can cause problems for soft tissue coverage in small children, especially in the junctions and apex regions. In this case, using fixed head screws instead of polyaxial screws, or simply bypassing this area without implants in case requiring long instrumentation can be valid alternatives. This is the issue is already covered by Dr. Aebi. In order to understand the spinal anatomy well, all congenital deformity cases should be evaluated with preoperative 3D CT. Discordance or mismatching between anterior and posterior elements is not uncommon. A careful preoperative analysis protects the surgeon from a major mistake that may be made during surgery. This is especially critical for hemivertebrectomy. Although the rare cases of pedicle absence involving multiple consecutive segments are encountered in some cases, this connection between the posterior and anterior elements, as you see here. These cases are not good candidates for pedicle screws and are not ideal examples for hook fixation as well. Rib fixation or anterior instrumentation options should be considered in preoperative planning. I don't know what's okay. As for challenges for related to corrections, sorry about this. I don't understand what's going on. Okay. The prerequisite of achieving reasonable correction without causing early implant failure or neurologic deficits is to increase deformity flexibility. Halo gravity traction is a frequently used adjunct method for congenital deformities. Deformities can be reduced and their flexibility increase with gradual distraction covering weeks or months. The most common additional intervention for rigidity are posterior osteotomies, from the simplest to most complex ones. I apologize from everyone. Okay. By combining Schwab 2 osteotomies with rib osteotomies, concave rib osteotomies particularly, reasonable corrections can be achieved in most complex, long sweeping deformities. In acute angular deformities involving a in acute angular, sorry, I'm just closing my screen and checking it. Slides, presentations, options. Okay, just a second. It works. Okay, this is the Schwab type 4 osteotomies. In acute angular deformities involving the short segments, the osteotomy should also include the anterior elements. In pure sagittal deformities, the Schwab 4 osteotomies may be sufficient, although it's very rarely. In three-dimensional deformities involving larger segments, removal of the vertebral body along with the adjacent discs or even multiple vertebrae may be indicated. The presence of concomitant spinal dystrophism is another clinical scenario that complicates our deformity surgery. I will not go on into detail about this topic as this is the topic of the next talk. However, I'll conclude my talk briefly summarizing our approach for these patients for whom there is still no widespread consensus. For many years, we have been performing deformity surgery in patients with syrinx or tetrad cord or type 2 split cord malformation under the guidance of multimodal neuromonitoring by strictly avoiding vertebral column lengthening maneuvers without performing any neurosurgical intervention. But if type 1 split cord malformation is within our surgical field, we simultaneously remove the bone spur sequentially and continue with deformity surgery. If the spur is outside of our surgical field, we don't plan any neurosurgical intervention for these patients. Here are some examples. Two separate patients with syrinx at the top, on the top and low conus on the bottom were successfully treated with shortening osteotomies without touching a spinal cord. And the patient at the top with split cord malformation, local deformity concerning the segments distal to the spur was corrected without intervening with spur, but in type split cord malformation type 2 case in the bottom, we absolutely don't perform spinal cord surgery. However, in the split cord malformation within our surgical field, like this patient, the spur was excised first by neurosurgeons. The dura was turned into the single tube, and deformity was corrected with the standard technique in the same session. As a take-home message, congenital spinal deformities can be safely and effectively treated with instrumented correction and fusion in January 2025. However, patients should be evaluated in detail before surgery. Surgery should be started with implant set prepared for all scenarios, including wire, cable, hook, rib hook, and pedicle screw and lateral mass screws. A meticulous surgical technique should be executed. Pre and intraoperative additional interventions to increase flexibility, like osteotomies, either posterior column or anterior column or rib osteotomies to increase flexibility, should definitely be planned and implemented. And type and location of intraspinal pathologies should be analyzed in detail, and the most appropriate method should be selected, and surgical intervention should definitely be performed under the guidance of multimodal neuromonitoring. Thank you. Sorry for a technical problem. I apologize again.
Thank you very much for this perfect overview. Are there any questions from the audience? May I ask you, in cases where you have a tested cord combined with an deformity, do you do a release of the tested cord before you start to operate on the deformity, or you do that together, or you do not do that because you don't want to lengthen the spine? So how do you handle this?
Great questions. First of all, we have to differentiate, and tethered cord is the MRI diagnosis or clinical diagnosis. And in most of the cases, we can see the conus should be a little bit lower than the original place, and also we can see some tight phylum. But most of the patients doesn't have any clinical symptoms. In those cases, if we are planning to perform any shortening osteotomies, like hemivertebrectomy or vertebral column resection, we are not performing any the neurosurgical procedure either before or simultaneously with our deformity surgery. But I think the critical point is you have to have a good multimodal neuromonitoring system. But if the patient having the low conus or tight phylum, and also documented progression of his or her neurologic symptoms, of course, this group of the patients should be considered differently. And simple answer for your question, our decision making is not based on the MRI picture, mainly for clinical symptomatology or clinical findings.
Thank you very much. I think this is also the way we handle that, but there's always the discussion, you know, together with the neurosurgeons. They always tell us we have to release first the tested cord, and I think it is very important to see whether there is a clinical evidence for this problem, you know. Okay, so is there a question? May I ask you? Thank you. This is that appears a bar. Concomitants, thing. How do you open the fusion in this different segment with osteotomy in addition? Very complicated question. Probably you should read yourself. I don't really follow that, you know what.
Each one is also in the facet fusion, you see? Appears unilateral increase the co-angle, how the open fusion, different segments of osteotomy. Okay. Yeah, some congenital cases, you're right, and the facet joints at the back is already being fused. But to make complete osteotomy, I mean 360 degrees for hemivertebrectomy or vertebral column resection, you have to make in the 360 degrees osteotomies. You have to release the spinal column and all from front and the back. In those cases, of course, you have to cut the facet fusion, facet osteotomy. You have to make in the facet osteotomy. And in those cases, usually we use the burr, I mean the Midas, or if you don't have in your environment, also you can do the facet, the excision. It's easy, even you can perform with the Carson Rongeur. This is not a difficult procedure, or the ultrasonic monoscalpel. Yes, the answer is yes. You have to release all the bone-bony connection from back and from the front. Dr. Aebi, may I give some answer for the previous questions you already discussed before my talk? Regarding the cage use, I'm the cage lover. I use most of the cases in the cage, in the small cage, not in the fancy and expandable cages, a simple harms cages. I mean, this is the 10-centimeter cages. It's good for maybe 10 patients. You can cut it and it's not too expensive. I use it in two reasons. One, a simple one is the practical one. Because of the serrated edges of the cage, gives some extra stability during the correction. It's not a huge stability, but it really gives some rotational and translational stability. But most important things, the simple hemivertebrae cases in small child, bone on bone, the contact would be perfect. I'm not arguing it. But in the older child, or the patient needs more resection, in those cases, if you compress the spinal column perfectly, you can create some spinal cord buckling. You can create some, if you shorten the spinal column too much, the spinal cord is going to be buckled and it can cause some neurologic problems. In those cases, to placing in the cage in the anteriorly, to get in the balance correction. You can distract anterior a little bit and you can compress in the posterior a little bit, or distract in concavity and compress in the convexity. You can get in the better balance. This is my point of view. And the second thing is about the robot. I believe in the question is not directly the robot. Probably the question is related to the navigation. The navigation is different. Okay, the robot is doing itself, but the navigation, it's the surgeon's helper. The navigation is not all cases, but in the revision cases or complex deformity cases in the small child, it's really useful. But in small child, also one of the drawback of the navigation, as the spine moves too much because of the body size and because of the, flexibility of the whole body, sometimes to interpret the navigation image is not easy. That's why the reliability of the navigation in a small child, at least in my practice, it's some questionable. But if you have a navigation in your institution, it would be good in some complex cases if you have some difficulty to understand anatomy intraoperatively. Even if you study it perfectly before, sometimes you can understand well. And finally, the bracing I already mentioned can be used as a time-buying strategy. It's not a definitive treatment, but time-buying strategy for the patient. Those have some big compensatory curves. And if you can postpone the surgery in the certain years, you can easily perform the simple definitive procedure instead of growth-friendly technique in the many surgeries over the years. That's my answer to previous questions. Thank you.
Thank you. I think I can agree with your argumentation. I mean, it's absolutely valid. You know, the patients where I'm involved in congenital deformities are usually very poor people who cannot afford the thing, so we have to get funding to treat them and things like that. I mean, if you have no limitations by that, I can very well understand your argumentation for a cage. But on the other hand, you know, the buckling of the spinal cord is, yes, when you do it in the thoracic spine, this may be a problem, but in the thoracolumbar spine, this is not really a problem. You can play a little bit with the distraction compression. But I mean, there is nothing against your argumentation. I think it makes sense, you know. I just think, yeah, most of the cases we just don't have that available. I agree also with robotics. You know, robotics is not navigation. If you have a well-established team for navigation and the system is well-established in your operating theater, this is certainly helpful in very complex deformities where the anatomical landmarks are very difficult to identify and so on. So that's also something which depends a lot of the pathology, what you treat, and the availability of the technology, whether you have available these things and so on. I can very well understand your argumentations. Okay, so have you other questions, or shall we go to the next speaker? I would propose that we ask Michael Falloon now to give his presentation about combined or separate surgery for split cord malformation and scoliosis. Please.
Thank you. I was going to add one more thing to the end there, though it might be a little bit of a resource thing, but for congenital, a 3D model to have sterilized on the field during the case is just an excellent tool to be able to navigate your own self and to reorient yourself during the cases to distances and give yourself a great advantage, I think. But again, that's a resource that's difficult.
Yeah, I agree with you. In fact, we have in context of a research project, we do 3D reconstruction of deformities. We make models, absolutely one-to-one model, and you can sterilize them and you can have it on your table and you can basically have your model at your hand and what you have to do in your spine. I think this makes a lot of sense, you know, in the complex deformities. I agree. Okay.